Yes, we are starting. Awesome.
Congratulations.
Hello and welcome to Slice of Piefer. I'm Dr. Piefer, here with the tiniest of angels,
Taylor Hayden, PA.
Taylor Hayden, PA. And we are very blessed today to have with us Dr. Brett Monroe.
Hello.
Emergency medicine, master and commander of the ER. Soon to be master and commander of the hospital. He's vice master and commander of the hospital.
You're the vice chief of staff.
That's an
Vice
official
chief of staff.
title,
Yeah.
I'm sure.
Yes, chairman of the credentials committee.
Yep.
Yes. So, I mean, as the Memorial Hermann overlord,
That is not true, but go on.
we've known each other for now. I've been there for 13 years, right? Give
Yes.
or take. And you have been there for
10 or 11?
10 or 11, just right after I started is when you started.
Correct.
Awesome. And we get to talk to each other late at night, middle of the night, texts back and forth.
All the time.
Just like best buddies.
Mm-hmm.
It's fun. But tell us a little bit about your life in emergency medicine.
Oh, man. It's a great question. I didn't know I wanted to do emergency medicine, actually. I didn't know about emergency medicine. I trained at I went to medical school abroad. I went to the Royal College of Surgeons in Ireland. And it's a 6-year program there. And emergency medicine there really isn't as high velocity as I guess I would describe it as it is here in America. There's not the gun and knife club, really. You know, it's more like cirrhotics and stuff like that. So when I came back, I had no idea what I wanted to do. And I knew that I wanted to come back to Houston because that's where I grew up. So a friend of mine was like, hey, you could do a preliminary year in general surgery at Ben Taub. I guess DeBakey, who was Lebanese, I think he's Lebanese, who was the big cardiac surgeon, had a program where he'd accept a lot of prelim years to do general surgery. And my mom was a radiologist, so she was like, look, do a prelim year if you don't know what you want to do. You do prelim year in general surgery. Radiologists, I don't know if they still do it or not, but it's a good year of just general medical experience. So if you want to function in a hospital, you'll know how to do a lot of stuff. So I did a year of general surgery at Baylor. And it's while I was at Ben Taub downtown in Houston that I sort of fell in love with the ER. I found myself wanting to spend more time down there. I know it sounds crazy when you know what an ER really is, but at the time, at Ben Taub. But there wasn't a residency program there actually at the time. They were just ramping up to start their first year. I was there. I like to teach a lot. I thought I was going to be an academic physician for most of my career. And I was there and I had a collection of medical students teaching them how to do history and physical exam. Because what I found when I came to the States is that the physical exam and the history was really secondary to sort of ordering a lot of tests and diagnostic imaging, right? So which is what it is. But at the time, there was a gentleman there who, in Europe, you usually say you expose people from, the nipple line to the knees, right? And so I would have these patients, this person was exposed. And I said, examine this patient and tell me what's wrong with him without actually asking any questions. Mm-hmm. So the medical student did, and they couldn't figure out what the diagnosis was. As it turns out, he had what's called a direct inguinal hernia or indirect inguinal hernia, which means that the hernia actually goes down into the male genitalia. Mm-hmm. And there's really a way that you can figure this out with any diagnostic imaging whatsoever, which is where you take a stethoscope and you place it on the male genitalia, and you can hear bowel sounds. Mm-hmm. So I had a medical student I said, listen, you need to auscultate a testicle, okay? And they did. And about 5 minutes later, the medical director at the time, I think her name was Angela Fisher, pulled me literally by my ear into the office and said, were you the doctor who is making medical students auscultate patients' testicles? And I said, yes, to diagnose hernias. And she goes, we're starting an emergency medicine program here right next year, right? I'd like you to apply. Mm-hmm. And that's how I got into Baylor's.
Really?
Yeah, that's a true story.
So that is amazing.
Yeah.
I mean, it's several things that I'm afraid of. Hernias, stethoscopes. I mean, that is interesting.
You can't borrow my stethoscope for a while, just FYI. I know that let you normally use it, especially for videos and stuff. I don't want you practicing.
I've never seen you with a stethoscope ever.
That is true. I did a video where I listened to the heart and lungs of the skeleton that we have for Halloween.
How did it go?
It was pretty good.
Did you hear anything?
I didn't hear much. I did try to listen to the skull as well to see if I could find a hernia.
Yeah.
But it was great. I mean, it burns my ears a little bit when it gets too close. It's tough.
So Ben Taub was, it was an experience, in and of its own, really. There's really nothing to compare what it's like, downtown Houston ER. And I'm sure Memorial Hermann's, the TMC is just as I don't want to say crazy, but definitely different, definitely wild, an experience to have. And then I ended up here and meeting you because I didn't know what I wanted to do after residency. I knew I wanted to do a fellowship. I was thinking about critical care. At the time, it was hard for an ER doctor to do critical care. So there was a gentleman named Mark Escott who was like, hey, he was the medical director for Montgomery County Hospital District. So I did a year of fellowship at Ben Taub, but I spent my time driving up from downtown Houston to the Woodlands. And you basically drive around for a year. You learn the area. I found Memorial Hermann. At that time up here, there was no there was only St. Luke's and Memorial Hermann. There was no Methodist. There was no Texas Children's.
No MD Anderson, nothing up here.
No MD Anderson, none of that here. So it was just the two hospital systems. But I like the area. When I grew up downtown. I didn't know what was outside of the 610 loop, to be quite frank. But I've been happy ever since I got up here. I don't think I'd ever go back down.
Yeah.
It'd take a lot,
It was wild as a med student at Ben Taub. So we probably were pseudo crossing each other's paths. I finished medical school in 2005 and was at Baylor. So we were rotating through Ben Taub that whole time. You may have come in right after me, maybe.
I think so, yeah.
Yeah. But yeah, it was wild. I mean, the ER is an experience like people just, it's got a little bit like being in the movies,
Yeah. I think that when I was there, it was a large room, the ER. It was literally one room. Mm-hmm. And there was just bed after bed after bed after bed after bed. And it was still all paper charts, so there was no electronic medical records. So there was paper everywhere. And it was probably one of the most functional disaster zones on a daily basis that I've ever been in. Also, you were surrounded by some of the most incredible people to work with ever. I remember there was I know this hospitalist, he was an older gentleman, and he's like, it reminds me when I went up to space. And I was like, what do you mean you went up to space? I thought it was having, like a senior moment,
I went to Wisconsin.
And then I was like, wait, I've been working with this doctor who's been an astronaut for literally like 5 years, and I had no clue. I just thought he was the hospitalist, right? And I feel like that is like sort of a common theme when you work there. I remember Ken Maddox one time told me to look at, he was I don't know if he's still there, but he was the head of trauma surgery. He's a very famous trauma surgeon.
Yep.
But he had said to read the book I think it's called The Hospital. I think Andrew Ortsack. I may be getting the name wrong. We can look it up after. But it was about the old Ben Taub, which was known as Jefferson Davis.
Right.
Which is what I guess Ben Taub ultimately turned into. But it was a wonderful place to train. I thought I was going to stay down there, but it was because of the fellowship and then being up here, seeing what, the life could be like up here and the opportunity was up here. I thought it would probably be better to just come up to Memorial Hermann, who at the time wasn't, it was with a different company called Team Health, which was staffing the ERs. But that's kind of how I ended up at Memorial Hermann and haven't left.
And I guess when you got here, we were level 3, or we were becoming level 3 maybe at that point, because we've since moved all the way from level 3 to level 2. And I mean, we are rocking and rolling in the ER now.
Yeah. So for people who don't know, for all of your 46 listeners, which is really 45 subscribers, by the way, because I don't count myself, 44 if you don't count yourself. 43. The difference between...
Thanks for being here, guys.
Hi, Mom.
I didn't mean to call you out, but we had a whole deal where I was going to show up only if you had 100 subscribers for that celebration. So maybe if you do well, this goes viral, you invite me back.
We're celebrating 46 today.
46 is the
46 is the new 100.
So you made me lose my thread now. I don't even remember what we were talking about.
We're talking about level 2, level 3.
Oh, yeah. So level 2 versus level 1 really is where the distinction is. So the question is in terms of capability. And when I started, I didn't even know what it really took to have a level 2 trauma center, which is essentially you have to have all of the ancillary services. And I'm probably not the best person to talk about it because I'm not like a trauma medical director, but you have to have plastics. You have to have, special type of ortho to do pelvises, right? You have to have all the sort of ancillary services that come with it. The only difference really between a level 2 and a level 1, usually I believe, again, if there's people out there listening, I'm sorry, is residents and doing research. right? But that's it. So the complexity of the cases is what it is at both. It's very, very difficult. It's very, very hard to do.
Yeah, there's very, very few things that are allowed to be transferred downtown from a level 2 that a level 1 will take. Some of them are the ophthalmology things, right? So like an open globe, which is an injury to the eyeball for my 43 people out there.
We're counting ourselves now, so it sounds better 46,
yes,
45.
I do.
Yeah.
I mean, I'm going to like it when I get home. I'm going to go push like.
I will too. I promise. I'll do it for you
I
as
will
well.
commit only to listening to it with the volume turned off while I take a nap. That's what I'll do.
So that's really, there's very, very few things. I mean, it's very, very, very few. So ophthalmology is one of those where ophthalmology, like most medical specialties, has become so subspecialized that there's guys who just do open globes, I guess, all day down in an OR suite. I think that at one point, Memorial Hermann did offer to build a suite for the ophthalmologists up here. They're like, we don't do this often enough to really warrant doing it. So that's really the only thing. But as far as the transfers downtown go, it's not a lot, considering when you think about, at least just for when I think about the Woodlands ER, because the ones that I'm responsible for are the Woodlands ER at the main hospital. We have a freestanding at the back of Woodlands Parkway across from Walmart. And then there's one on 99, which is called
That's
the
right
Spring
next to my
CCC.
favorite. That's next to my favorite French bakery, by the way.
Is it really?
Yes.
I've
the
never
French
been.
Oh, it's so good. So good.
What was
we
it
take
called?
The kids. It says on the outside French bakery, but I got to come up with what is our. I can give you the name. The up above it. It says, so if you look at the Memorial Hermann to the left, there it just says.
I was just trying to
Bakery.
think of you getting sponsorships from the French bakery.
Well, the whole company there. I go there a lot, but I'm now realizing that I go there so often that I just know that it's like my little family bakery.
Yeah.
But we have a blast. Their food's really, really good. But yeah, I like that. I love the ER back in the back of the Woodlands. It's awesome.
Yeah. So I think that, on average per day between the 3 sites, I usually think about it in terms of just 3 numbers. So about 150 patients per day at the main, about 30 at the CCC, and maybe 30 at the freestanding in the back of the Woodlands. So, almost a couple hundred patients a day. Maybe not very often per day are we sending people downtown, if we're sending people downtown, on a daily basis.
But 200 plus patients per day.
Per day.
Every day, 365 days a year, essentially.
Yeah, pretty much. I mean, there's variation, right? Some days are busier than others. Obviously, there's a sort of natural, circadian rhythm, the way the ER works. But usually, when you have to do these things called like staffing to demand analysis, super boring. But basically, the volume really starts to ramp up at around 9 or 10 a.m. and then really doesn't tail off until 1 or 2 in the morning. And then you get that lull. Yeah.
Because you usually have one provider in the ER, one physician provider in the ER overnight, right? From 1 a.m. forward or 2 a.m.
Yeah. So the way, at least the Woodlands main hospital, so the freestandings are a little bit different. The freestandings are one doctor works during the day and then one doctor works at night. So these are 12-hour shifts. They're all volume dependent. Like we recently just added some nurse practitioner covered one of those ancillary sites because they're busy during a day like Monday or Tuesday. For the main ER, we have coverage. There's always an ER physician there, always board certified. And there's also a couple nurse practitioners, or at least 1 or 2 running around as well.
Nice.
So yeah, to sort of meet the volume. There's a point though where you get big enough where you need to have a couple more doctors around. And that's always something that I sort of keep an eye out for.
Yeah. And I mean, and that's a push point. We see compared to when you started, it was not uncommon as the orthopedic surgeon on call to have a night or 2 nights or 3 nights out of your month of call where we got no calls at all.
Yeah.
And now I would say it's the exact opposite. Like it's much more common that we have 3 or 4 or 5 surgical cases, even on a random Tuesday or Wednesday, than that one off every quarter that I'm on call that I don't get a phone call at all. And I got to make sure is my phone on, And I'm like, why am I not getting phone calls? This doesn't make sense. So we've definitely seen volume, at least in my mind, volume has ramped up quite a bit over the course of the last 10 to 12 years.
I think when I started, we saw 85 patients per day. So now we're at around 150, like I said, at the main site. So
yeah, so we're
doubled
100% increase.
Yeah. It's gotten busy.
It stays busy as all get out.
Yeah.
And then was crazy busy during COVID, right? I mean, that was just like, I mean, that was more like 300 plus a day, right? That you guys were seeing.
Yeah, I don't know if it ever got. I don't remember. Honestly, I try to blur some of the stuff out. To be quite frank, COVID was an experience. But yeah, it got. So basically, during COVID, it depends on when you sort of realized what this was going to become. And I know this is like a controversial topic. I feel like everything's controversial now.
We're all about controversy here.
Yeah, you're trying to go viral. I get it. Right. So the
buzzwords.
Yeah, there was a lot of I think late adoption to what was really going to happen here. I think that since then there's been a lot of revisionist history of what it was sort of really like. I think that actually, honestly, I probably won't do it as much justice as probably the show The Pit. Have you seen The Pit?
I was about to ask you if you've watched it.
Yeah, we can get there. I'll explain it to you. But yeah, so COVID was one of those things where, you realize quite quickly that you're the plan. Yeah, because unless you're coming up with a plan, you don't know. And I remember thinking, if this is half as bad as I think it is when it was happening in Wuhan, it's going to happen here, and how do you deal with it, the patients, and more specifically, I was very, very concerned about not only the COVID patient themselves, but everybody forgets that there's a whole other cohort of people that were coming in for other stuff as well. People right. getting chemotherapy, people who were just immunocompromised. So, we came up with sort of like a split flow, negative pressure area to triage and sort of house anybody who had a cough, a flu, or whatever they right. had. The first wave of COVID, it was pretty intense down there. It was a lot of fear, a lot of anxiety. But I think that we had a pretty good plan in place from the jump. I don't think that at least our emergency department was behind the curve on sort of the early adoption of good best practice, even though the recommendations that I was getting or that I was reading about from some of the sort of national organizations, I won't say that I disagree with them, but I didn't have a lot of the faith in some of the recommendations. I didn't think that we handled it a bit differently. And I think that it worked out well.
I think that's a piece from COVID that people don't like. It's hard now to look back 5-ish years later and look back and remember that. Like I don't ever remember in training, medical school, orthopedics, Birmingham, Alabama, downtown Houston. I don't ever remember a time that I sat in a room with physicians where you could tell that people were afraid, where people knew that something bad was happening. And we were meeting, the medical executive committee was meeting sometimes 5 days a week, sometimes having meetings on the weekends. This is a committee that meets once every 30 days to kind of for 2 hours. And we were having 2-3 hour meetings every single day to try to figure out what the heck are we going to do?
Yeah.
And that part, like the whole shutdown and all those things that are super controversial, like what I would hope is that just like in medicine, you can look back, we can take a retrospective look, say, here's what worked, here's what didn't work, here's how we're going to treat this in the future. And I think that there's pockets of medicine that can do that, but it became so politicized that now anytime that you admitted, like one of the beauties of medicine is you can say, we tried this and it didn't work, we were wrong. And you can feel very comfortable and confident saying we were wrong and that your colleagues and everyone else in the community says they were doing what they felt like was best. And now when you go back and say, hey, remember when we had people wearing masks outside? Well, that probably wasn't, that was not a smart choice. And we didn't really need to do that. But now it becomes, well, you were putting muzzles on people and it became so political and so emotional. And the reality was it was such a challenging time to be in it. And you, more than me, were in the throes of it, right? I mean, you were on the very front line of these people who were coming in, and that was crazy.
I think that when I look back and I think about it, I don't know if the general public, now that we're removed from it and obviously hyperpolarized and politicized, realizes that there were times that, when we had to cancel like all of your cases, all of your elective knees and hips, right? there was no room at the inn. And, the knowledge that we were gaining, I remember very clearly intubating people and being like, man, they're getting so much worse. Like, what is going on? I've never seen anything like it. And we had so many people on vents that there was just no room to do kind of anything else. I get the idea of wanting to flatten the curve, right? I think that it worked to a degree, but only because if we continued during that first, and then you remember the delay, and then the second big peak, we would have not been able to function and take care of anybody, right? So I guess it kind of goes back to, what do you call, or what's the definition of a disaster? And I may be wrong in the definition, but I always understood it as when your need outstrips your resources, right? Now you can make a soft argument that in any ER on any given day, when there's 20 or 30 or 40 or 50 people in the waiting room, you fit that definition of a disaster. Sure. But with COVID, I do believe that there were weeks and prolonged month and a half. Because remember, those people, once they got admitted, they didn't go anywhere, right? They stayed with us for months. They were so sick. And so, the hospital, you have to get people out to get people in. And under normal circumstances, we do that all very well. But when you couldn't transfer the patients anywhere either. Right. But you still have people coming in the front door. So you add on, it's funny, you go back, you add on that if society was functioning normally, and you would have had all of the level 2 trauma stuff come in, right? I'm not exactly sure how we would have done, or just exposed them because we saw the sickest people, right? Because these are the people who had COVID and decided to come to the hospital, right? So,
yeah, it was crazy because I think that for us, Memorial Hermann, right, in the Woodlands, the numbers are not going to be exact, but I think we had 330 licensed beds, and at any given time had well over 400 plus patients in the hospital.
Yeah.
And that was crazy.
I remember, this is before, I don't remember the date. I was thinking it's March 16th is when America sort of realized something was going on. Was it March? We had a plan though. There was a way to clean the ER. There was a way to triage patients. There was a way to, I remember my wife always tells the story. She goes, you went to Home Depot and bought, I sent out the nurses to grab clear plastic sheets. So when I read a study or watched a video on respiratory droplets when you're intubating people. So I'd cover people in plastic because I just wanted to protect the droplets. We made the trauma rooms negative pressure. So at least, people could, function within the ER and at least limit the amount of droplets in the air because we didn't know. But yeah, the moving on from that, I think that, since COVID, I've personally seen a change in, the way, people, behave in the hospital and the way things are going. I think that since that time period, if I look at things like, violence in the workplace and patients being angry or feel like something's not right, or their trust in doctors or nurse practitioners or whatever titles you want to give people, is something that unfortunately has been eroded. Faith in institutions across the board, I think, is something they're all suffering from to a degree. I don't think any of us became doctors or nurses to want to engage in politics. We just wanted to take care of people. It's becoming harder to do,
Yeah.
It really, really is. And it's since that time. And I don't know if I feel that way because that's sort of when I was a young physician just into leadership at that time. And that's my perspective. Kind of that's where I start from. I will say this though. I'm glad it was me. Mm-hmm. I'm glad that I was there.
Yeah.
I think there's some things I would have done differently, not much. Because again, you're living in a world of rumors. You don't really know what's going on, and I felt that way a lot during that time. Also, I will say this, Memorial Hermann gave me pretty much everything I asked for, right? So the hospital system itself, we got all the resources that we needed, but more important than any of that is I'd been a part of hiring everybody that I worked with. Right. So not as much the nursing side, and they were fantastic, but the doctors that I have working there, there's about 30 that work under me. I'm their medical director. But
Master and commander.
Well, stop. This is ridiculous. Let's put it this way though. There's something that you hear generals talk about. You don't go to war with the army you want. You go to war with the army you have. I got both, right? Yeah. I got to do it with some of the best people that I often make the joke that I don't want to work in any other ER after this one. And it's because everybody we've brought in, it's not like a traditional executive position, right? Like in most executives, they hire people into an organization and then they go, oh, how are they doing, right? When I hire somebody, there's a great chance on any given day I may be sitting next to them for 10 or 12 hours, right? Doing ER stuff, which is a lot of the time is unpleasant, So yeah, no, I wouldn't have wanted to do it with anybody else.
That's awesome.
When I remember when it started, there was the concern about what was going to happen in the ERs. And so I remember Dr. Piefer and I talking at the time, and we like the whole clinic, the whole Woodland Sports Medicine decided we were going to try to offload as much like fractures and things like that into the orthopedic clinic, things that we're not used to seeing walk into the clinic, right? That would go to an ER traditionally. I was thinking things like distal radius fractures, things like that. The first time I knew things were real was we had this like super elderly man come in. He couldn't weight bear, couldn't get up, I literally had to pick him up and transfer him to the x-ray table. And I was like, this guy's going to have an intertroch fracture that just came into an outpatient orthopedic clinic.
Yeah.
And I hadn't seen that in my career at that point that was in 2020. So good Lord. I mean, like it was just amazing to me that guy, and I was like, why are you here and not at a hospital? And he's like, I don't want to die. I think I'm going to die if I go to the hospital.
Yeah.
And he was that terrified, knowing that he had probably broken his hip, which he did. He had an intertroch fracture. We're like, yeah, we got to get you over to the hospital to fix you. We can't fix that here. And he was like, I'm going to die there if you send me there.
I don't know if anybody ever did any, I know we didn't. I don't know if anybody ever did any, intra, hospital infections and mortality rates from that, But I was something that was always on my mind. It was something that I thought about constantly. Like I said, you have somebody who's getting chemotherapy. You don't want to put them next to the person who's coughing. And then you have the whole issue of the waiting room, right? How do you do that? Because, the ER only has about 35 beds in it, right? So, it was a challenging time. But I think we did I honestly think that we did as a team as well as we could. Like, I think, like I said, like I don't have a lot of, regrets in terms of the decision making that was made, because essentially I think that the team came together. We kind of had a plan. We kind of figured out what worked and what didn't. We realized PAPRs weren't going to really work for us. N95s were okay. We realized maybe some of our infection prevention stuff was a little bit over the top, so we were overly cautious, and then we sort of slowly scaled back, right?
Yeah, we were looking at trying to have the orthopedic hoods, see if we could make those work.
Yeah, I remember. Yeah,
like, we were like, but I mean, we were like, well, if we use the wrappers from the OR and we cut them and we use that as a filter, because the orthopedic hoods are the exact opposite of what you would typically want. They would block the droplets, but they had basically a fan that pulled air in. So,
what do they call it when there's a flood? Whenever Houston floods, it's I don't want to say a derogatory term on a podcast that goes out to the public, but do they call it the redneck army? The people who come out and save people on boats, or
Cajun Navy.
The Cajun Navy. Yeah,
the Cajun Navy.
I feel like we were channeling our inner Cajun Navy a lot of the time during COVID. I'm like, where's the duct tape? Like
we're trying to fashion everything
the Cajun
we could.
Navy. That's right.
Yeah, the Cajun
I apologize
Navy.
if I offended anybody, but yeah.
Oh, I don't think the Cajun Navy would love that.
Yeah, you're welcome.
They're
Hashtag Cajun Navy. 46% subscribers trying to get to 50.
Come on
the podcast.
We can get.
If you get somebody from the Cajun Navy here, I'll come back.
Yes,
Perfect.
Yes. Yeah, I'll text you next week.
Do you feel like the TV show The Pit, when it talks about like COVID and stuff, do you feel like that's accurate based on your background?
My experience with The Pit. So shout out to Noah Wiley if he's not watching, because he's not. He's one of the 43. He's not. I'll send this to him, but he's not.
We think positively here.
Okay.
We believe.
I would say that I watched the first episode and I had to stop it. Right? I had to stop watching it. And I think that if you were to ask me for an accurate theatrical representation of what an ER is like, I would say it's pretty close. The only difference is though that like all of the amazing medical stuff that you see happen in The Pit happens in like an episode. So it's just time compressed, right? But all of the things that you see there a lot of it happens. It just may only happen once every 3 years, not in the first 24 hours of your, or 12 hours of your shift, right? I mean, like, are you kidding me? Like, I'd be grayer than I am now. I'd be already in retirement. Yeah. So, but I would say it's definitely
accurate,
pretty accurate. I mean, as close as you can get. They definitely did their due diligence, right? Mm-hmm. Like when they made the show. And I think that, it was, it's timely, at least for us. I know that I have friends. We have some close family friends, and they have kids who are in high school, and they're like, was it like that? Is it like that? I'm like, yeah, it really is, except the time thing, you know? But I would, if you're curious of what it's like in an ER, I think that's, other than coming and spending time with me in one, right? Mm-hmm. I would say that's a pretty good.
That's an invitation?
It
depends on who you are.
That doesn't depend on who you are.
If it's me,
you're not invited.
We see each other all the time.
You're invited.
Yay!
Taylor is invited.
I would love
Taylor's invited.
Oh
I would love it. I loved my emergency medicine rotation. I thought that was in like the top 3 of things I wanted to do. I really loved it, and I begged for the bin top rotation. And I was like, put me where I'm going to get the most experience. I want level 2, level 1, and College Station, Texas is where I ended up doing my ER rotation, which was awesome. I had great experience. I loved it. I loved seeing how much. There was just so much collaboration between the physicians and the advanced practice providers, nurse practice PAs like me, and they just let you. They let you learn so much. You learn so much on that rotation, and if you don't like procedures, you probably won't like ER. That's not going to be your jam. You're going to be better suited somewhere else. But I loved it.
I love the OR though, Dr. Piefer, speaking to your specialty. The problem with the OR, in my opinion, is that one, sometimes there's surgeons in the OR. Yeah. You guys are your own special breed. But the second thing, honestly, is at the table, for me, I'm like 6'3", 6'4". I feel like I started talking to doctors who are like over 6'2" or 6'3". They all have just neck and back problems, but I love the OR. It's just the table doesn't go high. There's only so many stools you could put Taylor on before she's going to fall and break her hip, to have the table at an appropriate height for me.
True. Yep. She has to use 2 stools for me.
For you?
Yeah.
No, that's not true.
How tall are you? 6'5", 6'6"? How tall are you?
6'6", 6'7".
6'7", that's right.
This tallest surgeon I ever had to scrub with was about that height.
Yeah.
And I had 3 step stools, and I still was trying to run the bowel like not in sterile field.
There was a surgeon downtown who I was like, well, how do you do it? Because I wanted to know, because I was doing the prelim urine surgery. I really liked it. He's like, you ever seen Metallica? I'm like, no. Well, yeah, of course. He goes, that first note, the intro E, where Lars has his legs like spread out. So you literally operate like doing the modified splits, And I was like, this is not sustainable.
Yes, that is difficult. That's a lot of pressure on the hips.
He's the exact opposite. He'll tell them to bring the table all the way down, and he's like, that's as far as it goes.
I think I'm shrinking.
I guess I'm getting shorter.
I think I'm shrinking.
Yeah.
What happened to the soles of my shoes? Yeah.
But the only time he ever has to use a step stool is if it's like a tibial nail or something like that, where he's got to get a little height.
But now with the suprapatellar nails, it's really nice.
Great.
Because the suprapatellar nail, you come in through the quad and you pass between the patella and the trochlea, and you go through there instead of having to go through the patellar tendon. So you don't have to have the knee flexed, which is really nice.
So no step stool for the surgeon.
Yeah. It's also beneficial for that. Yeah. So it's all good. We talked about leadership. Obviously you've got to do some leadership in the ER, and also now medical kind of administrative leadership. And do you have a master's? Did you get a master's in health administration, or?
I got an MBA.
MBA. Got it. So a master's in business administration.
But really, that all came from being frustrated at Ben Top, to be honest with you. I remember walking around being like, why doesn't this work? Why is this so hard to do? Why is it hard to function and get things why isn't it there? Like in the OR, I know you're usually just like, and somebody hands it to you, right?
Just like that.
Just like that. So I remember, being frustrated, and I remember he was the chair at the time at Ben Taub, and he was like, you look pretty frustrated, Brett. And I was like, I am. He goes, listen, you need to go to Tennessee. I'm like, what? Like, why? He goes, there's a couple guys there. There's a physician executive MBA. And I was like, well, what is that? He's like, they're going to teach you why you're frustrated and then show you how to fix why you're frustrated, right? So the guys who'd really written the book on ED throughput and operations, Jody Crane and Chuck Noon. Chuck Noon's a professor there. Jody Crane, I think, is now the CMO, Chief Medical Officer for Team Health. But they wrote a book on ER operations and throughput using queuing theory on how to show up at the right place at the right time for providers and nurses, and then your beds and how to do all the math behind that. But really, it taught me that there's, a process for the process being fixed, right? And that's when I really became interested in you always refer to me behind my back as the systems guy. Like Monroe is going to look at the systems. Yes, that's you. You're always like, I know you think systems, right? But like, I think that a lot of leaders, I feel like, especially when we were growing up, because I know you're in your 60s and I'm in my 40s.
True.
I'm actually a year older. I'm 47. You're 46. But they grew up with sort of like the Steve Jobs notion of the greatest executive ever, right? Which is sort of like, even the what was her name, Theranos, who all of a sudden everybody started wearing a black turtleneck, right? But the sort of visionary, sort of idealistic, right? And I get that. I think that you have to inspire people. I think it's important. But I also believe in competency, right? You have to be extremely confident to do what you do. And one of the things that I found there at University of Tennessee is that there was a process to fix these processes if you were competent enough to do it. And so I literally stole every great idea that I heard there, and I brought it back to the Woodlands as a result. I think that great leaders will, the place will function well while they're there. The best of the best, it functions better when they're not. So literally my goal usually is to look at a problem set, use data-driven sort of decision-making, but make something that out-survives me and then is better than when I showed up, right? And the idea, and the other thing is that the more controversial the idea, the better, in my opinion, right? I think that's one of the pitfalls with leadership sometimes is the narrative becomes more important than anything else. The optics of the situation become more important than anything else. And I think it's something that you have to guard yourself against, right?
Right. Mm-hmm.
Sometimes that you have to sort of pull back and be like, look, I know what the narrative is here, but like this is how it's really working or not working, and invite dissent, right? So I prefer the arguments to be intense because I think that the solutions are much better when they are.
Mm-hmm.
Fisticuffs.
I wouldn't say fisticuffs. I got a glass chin. I'm a reader, I like to read.
I like it.
But yeah.
Yeah, I mean, I think that to say, that idea that being outside and having enough trust in your team, both the doctors, nurses, nurse practitioners, PAs, to be able to run the show and even to be able to run the show even better than if you were sitting there in the midst is pretty impressive, right? That's a pretty cool position to be in as a leader.
Yeah, I don't know if that's the right way to do it, right? But that's the way that I think, at least my ideal of it is.
I think to me, that's kind of the definition of success there. If you can empower your team so well, and if you can do that and empower them to do the job so that they do it better when you're not around, then that's awesome. That frees you up to do so many different things in terms of helping to manage, in terms of helping to continue to lead from afar. Now, I think that just like we hear all the time, you got to be willing to get in the trenches and do things that if you're not willing to do the work, then it's never going to run like that if people feel like he's not willing to do the work or she's not willing to do the work.
It's that visionary versus competency, having those two things together like you were talking about.
And I don't even like to use the word visionary, really.
Mm-hmm.
I prefer strategic, right? So
strategery, maybe
a little strategery. I think that really, to me, it's it's all about, not as much, I don't know, just the visionary just bothers me for some reason, because it makes me think of a guru, and I don't think anybody knows anything, right? Like, I think that, there's probabilities,
Get that
right?
New Age stuff out of here.
Yeah, I believe in probabilities, right? And if you believe in probabilities, you have a good chance of never being wrong because it was probable, right? So I try to think about a series of outcomes that are so desired and then being like, okay, we're going to fall in sort of this distribution curve of that when it comes to it. I know it sounds strange, but I think that pushing yourself to imagine what this, at least, for me, the emergency department or what the hospital will look like in 3 years or 5 years is challenging. I think when you start trying to think a decade out, for me, that's a stretch, right? I know that, like, I remember, a few years ago, the book Moonshots came out about people making these huge, financial investments for things that they hope that would pay off 15 and 20 and 30 years later.
Right.
I'm not that good, so I'm worried about tomorrow, most days, But
I think that I think that that's part of it, though. I mean, I think when you're trying to set those goals and you're trying to lead from that position, right, you've got to be able to reach out and say, this is where I want to be. This is where I want to see you. This is where we want to see this facility and this organization. And then the crazy part is, like, I mean, you can tell me, because I love what I do and I have fun all the time.
Yeah.
And so, like, that part for me makes it easy. It makes it really easy to lead. It makes it really easy to work. It makes it easy to get in the trenches. It makes it easy to step back and joke around and do stuff. But I mean, I just have fun doing it. And I don't know do you still have that through leadership and being there? Do you still feel the fun? Do you still enjoy it?
I don't know if you can work in an ER and be serious all the time. I think that we're known for our dark sense of humor.
That's a load-bearing structure, that dark sense of humor. You got to keep that there.
Yeah, I think it's our coping mechanism. I do think it's fun. I like I said, I think it all comes back to the people that you surround yourself with, and I have literally surrounded myself with the best, in my opinion, and I'm happy to argue that with any other medical director anywhere in the city, right? So with that, like, I think that also I trust the people that I work with. I think that they trust me. I think they question a lot of the decisions that I make, and I think that's perfect. That's exactly where I want it. I don't want to be surrounded by people who are telling me, what they think I want to hear. I think at that stage in leadership, you're in trouble, right? And you're going to get in trouble. And I think that you'll miss sort of a lot of good dissent is there for a reason. And I believe in, a lot of the time, when people talk to people in leadership, I don't think they know how to communicate without seeing. You can dissent but be respectful, right? And I think that's sort of the clutch of being a disciplined dissident, I guess is what you'd call that. You have to be a disciplined dissident. Sometimes you have to tell people what they don't want to hear.
She's my disciplined dissident.
That I believe.
Disciplined?
Yeah, discipline. Yeah, that might be a little bit of a stretch.
Designated.
So, I mean, you've really talked about separating the difference between good leaders and great leaders and what you feel about leadership, which is one of my big questions that I typically try to ask everybody, because leadership is something that I'm passionate about, but I also just I enjoy it and have a good time.
Do you think you're good at it?
I don't. I think I'm one of those people who really believes you can always get better.
Yeah.
So, the
enemy of good.
Right. I don't think when I look in the mirror, when I look in the mirror at myself in general, I say that guy's going to have a great day today.
Every day.
So that is true.
Every day.
So don't get me wrong. My self-talk is pretty good for me, but if I was rating myself as a leader, I always think I can do better. I can always be better. So I would say there's a long way to go in that realm for me. But where was I going with this? Talked about leadership. Oh, what would you do if you weren't doing emergency medicine? What would you do? If you weren't in medicine at all?
Yeah.
If you could choose something outside of medicine completely, what would you choose? And why?
Oh man, that's a good question.
I'm interviewing you for a job. Also, what's your favorite color?
My favorite color? Red. That's easy.
Nice.
I think that I'd probably do something more entrepreneurial. I think that I'd probably run my own business, outside of medicine. As to what that would be, I'm not sure. I know that I like data. I don't know if I would have ever gone into computer science or anything like that.
Yeah.
But it'd have to be something that you dealt with people. I think that at one point I was most likely to either have my own talk show or be homeless. So, anything in between here and there would be fine as far as I would be concerned,
You're on your way.
Yeah.
You got this.
To being homeless. I know.
You're always only like 2 steps away or 3 from being homeless.
I'm known at HR as well. So, they know me,
they follow you.
They know me. Yeah. Something that, would probably be data-driven, entrepreneurial in that way.
That's
but
awesome.
I'm not sure.
Very cool.
Yeah.
Well, I want to thank you for coming.
Well, thank you.
Favorite type of pie? Key lime. Easy peasy. Very nice. I'm a lover of key lime pie myself, but I go for the chocolate stuff. This is your beautiful
Thank you.
key lime pie. You don't have to eat
appreciate
it. You don't have to eat it here, and we're not going to smash it in your face, so you don't have to worry about that.
I wasn't concerned. I trust you.
Good.
That trust is only slightly misplaced. Only slightly.
Have you ever had a pie in your face before? Stop. From him?
No.
Oh, see, there you go.
Yeah, I've never done that. That's tough. That's a tough one. But I do want to thank you. Thanks so much for coming. You were awesome. Very well done. You can come back anytime.
Really?
Next week if you want to.
Okay.
And the week after.
What will we talk about next week, then?
We can talk about anything you want. Anytime, basically.
Okay.
We got all kinds of stuff. You
Squeaky shoes.
Get another
Talk
pie.
about those.
Squeaky shoes.
Do I have to change my recommendation? Or could you become
just
sort of like my
your key lime
resource
pie
for key
dealer?
lime? Yeah. Exactly.
I can do that. A pie dealer seems like a reasonable choice for me. But
If he wasn't a doctor.
if I wasn't a doctor, I would become a pie dealer.
Is this where you want me to plead to your audience to like and subscribe, please?
You don't have to plead.
No,
We
you
can
need to
just do
it,
this.
guys.
Listen,
It's 46.
listen. There's so many subscribers now. It's really getting tough. But you can listen. You can hear them.
It's terrible. I mean, just terrible.
It's so good.
It's really the
It's so
crickets.
good. But even better than that is this one. And lastly, we dance.
Unbelievable. I can't do it.
You can do it. I believe in you.
Maybe
Just-
a little shoulder. With the shoulder.
You can keep it here too. This is always safe.
Get me out of here.